my case, my patient has excessive femoral internal rotation as well as excessive adduction as well as contralateral pelvic hip drop when they're walking. So in this case, for their affected side, which what I'm demonstrating would be the patient's left side that's injured. For the phases that are affected, it's going to be specifically mid stance as well as terminal stance. So once their affected side is behind the other foot that's starting to advance is when they're going to have some of those issues. The functional tasks that are affected is specifically single limb support. And then within those, the task accomplishments that are affected is going to be forward progression as well as stability. The two main issues with those is that because they have difficulty with stability due to the contralateral hip drop, it ends up creating a narrow base of support, which then causes more of the femoral adduction. With forward progression, patients are often going to compromise with circumduction of the left leg, which also will create other issues as well. And then for some potential causes that could be some potential causes for this gait deviation, the main one being they could have a weak glute medius. So if they had like hip surgery and the surgeon had to, cut through the glute med and, like a hip surgery, that's going to be an issue on their left side. So then they're going to have that contralateral hip drop because the left side isn't strong enough to keep the right pelvis stable when they're walking. It could also be present in like excessive runners, for example, that are consistently having that impact, as well as just low back patients that would also have weak hip muscles present. It could also be due to like structural alignment. So if someone has excessive aneversion, which would be over 15 degrees, that's going to create femoral internal rotation, and then the patient's going to have to compromise with a bunch of other things. We also could say the patient would be overpronating when they're walking during gait, and that connects to having excessive knee valgus, which could just be due to poor neuromuscular control as a whole. And then we could also say this could be due to tight internal rotators or tight adductors, which will create all sorts of issues, specifically more lateral patellar stress issues.